without further ado, it is my pleasure to introduce Dr. Chu. He is an associate professor in the Division of Gastrointestinal Surgery at the University of Alabama at Birmingham. He completed his undergraduate studies at Yale and medical school at the Johns Hopkins School of Medicine. After residency at Boston University Medical Center, he completed a colon and rectal surgery fellowship at Mayo Clinic. His clinical practice specializes in the spectrum of colorectal disease, including inflammatory bowel disease, colorectal cancer, diverticular disease, and anorectal disorders. And his NIH-funded research interests focus on identifying, understanding, and reducing health disparities in surgery, with particular attention to health literacy. And with that, take it away.
Great. Well, thank you for this chance to join the virtual education and to talk a little bit about health literacy. Feel free to drop questions in the chat box. Normally when I do this in person, we have lots of interruptions and tangents, which is fun to talk about. So at the end of today's talk, I hope to share and give some ideas on health literacy in surgery, in colorectal surgery, and why this matters, and what you can do about it. So I have no commercial disclosures, but do have some grants. And part of this talk is also to provide some ideas to show that you can do successful research within spaces like health literacy that might not seem very clinical and more traditional. But the NIH has a high interest in these areas. And so I hope to give the audience some ideas on this, perhaps for their careers. So the talk will be structured to try to tell a story about health literacy. The problem, what is health literacy? I want to show why it matters. And I also want to give some practical examples of what we've done in Alabama to address this issue and predict some future progress within this space. So let's define the problem.
So what you do, you come out of that room, that examination room, with this intelligent woman or man thinking, God, I hope I don't make a mistake with my medicine, because I did not understand anything he or she said to me.
When your children have fever, what do you usually give them?
Motrin or Tylenol. Normally Motrin, because that's what my doctor recommended.
How old is your daughter?
She is 4.
She's 4. Okay.
I would give her the 4 to 5, a tablespoon and a half.
So you give her a tablespoon and a half. Can you find where it tells you how many you take? The dosage?
A day?
Take 3 to 2 milliliters. And there's something I want to point out. I don't actually read this because I know what it says now. So if I had to sound it out, if it wasn't for I knew it, because I've heard it so many times, I would not be able to read that.
Okay.
Every 3 to 4 hours as needed for pain.
Okay. What's a milliliter?
I don't know.
The medication that was given to her was not explained. Well, we didn't use it.
In fact, she ran out of her high blood pressure medicine, so she didn't take it. She didn't call me to tell me to fill it. So finally, I found out that she had not been taking it. I said, Mother, you can't do that. You have to keep taking that high blood pressure medicine.
When you get your prescription, you get all this stuff and just throw it away because my eyes are not that good.
And then it says discontinue.
Yes.
What does that mean?
I don't know.
How many times do you take these thyroid pills?
Once a day.
Okay. Do you take one of each of these?
Mm-hmm.
Okay. So you take 2 thyroid pills.
No, I take one. I more likely got them messed up when I got refilled.
And then are these stickers helpful?
Nope, don't even look at them.
Don't even look at them.
What do you take that medicine for?
I don't know what it's for. He just puts me on stuff and you tell when I have it, I just take it.
So that video was made in the 1980s by Pfizer as part of a grant looking at health literacy and medication adherence. And I think that was done, in the 80s. But I think you still see that in all the different comments and confusion within your own surgery clinics every day. And that really touches on this idea of health literacy, which is this definition right here. Now, this definition has evolved. Previously, we thought it was just really at the individual level. You as a person, your ability to find, understand, and use information to make decisions. That's what we classically thought of as health literacy. But there's another level now of organizational health literacy. So your hospital, your academic center, the degree to which the organization helps patients find, understand, and use information. The bottom line, though, is this idea of health literacy really permeates everything that we do in healthcare, right? From getting access initially to evaluating results, to calculating doses, how to take your bowel prep. These all require an ability to process and understand information. And so this is why it's so important. And it's not just for surgery, it's in everything that we do in healthcare. Now, surgery is very interesting, as we all know on this call, because surgery is very much a journey. There are so many steps to the process, from the patient getting sick, to meeting the surgeon, to going to the hospital, surgery, recovery, going home, you name it. Every element of this process requires health literacy. And while as surgeons, we oftentimes say things from our perspective, and it seems very obvious to us, in reality, on the flip side, patients can be very much confused as to why they're undergoing surgery, what it actually means, what they need to do when they're at home. And so I think all of us on this call can really kind of touch upon this and think of examples of this happening. Now, people have really formed the definitions of health literacy and figured out that there's multiple dimensions of health literacy, as shown on this slide. So while previously we thought health literacy was really reading and writing, we know there's also a verbal component of health literacy, and now visual elements, information, and even technology with all the stuff that's out there right now. So health literacy really falls into all of these different areas now. Now, for those who love to ask, can we measure health literacy? The short answer is absolutely yes. So while you can see here in 91, that was the first test to look at health literacy, called the REALM test. This was just literally reading a list, showing a list of words to a patient and having them read it out to you. But you can see this has evolved over the many years now to over 200 variables that can be measured. This website is a great tool shed. It is the Bible of health literacy measurements that you can go to that explains everything, and they're all validated, and it can be used within your clinic or research study to measure health literacy. Now, why else is health literacy important? Well, at the multiple levels, institutional, federal agencies, all of these agencies, as an example, have language on health literacy and specific aims of addressing the issues of health literacy, because it's such a big concept and big process that affects everything that we do within health. Now, in 2003, we had the biggest study done on health literacy, where a group from the government went around the country and looked at many families, went into their homes and administered a test. And really it was meant to assess just literacy in general. But out of those tests, about 28 were actually related to health. And so that's how they could assess literacy towards health. And this is what they found. Out of all of these adults, essentially only a tiny sliver of patients, shown in the green, had the ability to calculate deductibles in their insurance. Whereas the majority of patients actually had some difficulty using and assessing things like the medications on a label and what to do. So while 1 out of 10 people were okay, 9 out of 10 individuals had difficulty using information. This is a significant portion, as you can imagine, of the population. And speaking just personally, even if you have education, even if you have a PhD, you can still have significant difficulty understanding how to use healthcare facilities, to follow instructions. My own father, PhD in math, had significant difficulties figuring out how to take the prep for the colonoscopy because the instructions were all text and hard to read. So this can affect really everyone. This is a map of health literacy across the United States. You can see in red are areas with very, very low health literacy, and green are areas with what we would consider proficient health literacy. And this map really mimics, for those who are interested in health disparities, those disparity maps, right? If you think about obesity, smoking rates, you name it, these maps look very, very familiar. On the left is the state of Alabama, where I am here in Birmingham. And you can see that in significant portions of Alabama, especially in the rural counties, we have major issues of health literacy. As a contrast, in Massachusetts, where some of you all may be, you have sort of a flip where there's a lot of green that you see here. But it's important to point out, though, that you can still see those pockets of red and orange, right? So these are areas that do have limited health literacy. And as an example, California, which is very diverse in terms of the levels of health literacy throughout that state. Now, why does health literacy matter? Well, because people have shown over and over again in the last 3 decades that health literacy is associated and in fact may be a key determinant of all of these metrics that's shown on this slide. And you can see it ranges from metrics such as mortality to readmissions and to medication adherence, as the initial video alluded to. And health literacy clearly is linked to each of those areas. Now, when we think about health literacy from a research standpoint, one of the things we love going to are conceptual models. So these models that really, on paper, help us think about how health literacy relates to health outcome. This is a great model that we use in many of our projects and grants. And you can see here, on one level, very simple. Health literacy is ultimately related to health outcomes. But health literacy is sort of predetermined. So that patient who shows up in your clinic comes to your clinic with a set level of health literacy that's sort of been predetermined by demographic factors and the social determinants of health. So your goal isn't really to change a person's health literacy. It sort of is what it is. The catch, though, is that someone who comes to your clinic, for example, with low health literacy, if you were to give them an ostomy, their challenges in terms of handling an ostomy, knowing what to do if the output's really high, is at high risk of having essentially poor outcomes. They're at high risk of having readmissions, high risk of getting dehydrated with acute kidney injury, right? We've all seen this. But the catch is not fated, meaning a patient with low health literacy doesn't have to have a poor outcome. You can do things in the middle, these modifying factors, to really change that direction, right? If you help patients understand that high output isn't great, and you can follow an algorithm to deal with this using medications like Imodium, that's great, right? If you give them on a sheet of paper that's all text written in 8-point font, will they really get it? I don't know. I don't think so. If you use it with pictures, then maybe they can. You help them understand it. So that's what you can do at the healthcare system level, the readability of information, the way you provide education. What about the provider level? And I'll show some data on this. But you as a surgeon can actually affect understanding on the way that you communicate, how fast you speak, the words that you use, your ability to give some time for questions. These can actually all matter and help patients understand things. So the point of this slide is just simply show you that you can modify and align better with someone with, say, limited health literacy to achieve a better outcome. Now, for those who might not believe me, we can look at data. One of the first studies ever associating health literacy with a health outcome was done in 2002 by this list of who's researchers now in health literacy. And what they simply showed, but you can see it was published in JAMA, is that when you measure health literacy, this literacy measurement, which is the TOEFL, is one of the tests, is associated with their hemoglobin A1C levels. So for patients with really good hemoglobin A1C, less than 7.2%, what they found is that the people who had the people who took up most of that proportion of patients had adequate health literacy. But the patients who had basically the worst diabetic control, most of those patients had inadequate health literacy. So a clear association, almost like in a dose response here for that. And this really represented the first study that showed this association and really was a call for action, saying we can do something about this and we should do something about this. So that study in 2002 was followed up by this study where they asked the question, can we do something? So what can you do about someone with low health literacy? What can you do to address it? Well, you can do this. This intervention as shown in upper right. Very simple, right? This is not a $2 million robot. These are things that are very, very basic level that you can put together to be more health literate. And this was a randomized study published again in JAMA. And what they showed is that for patients with limited health and low health literacy, if they went this intervention, this counseling, this improved communication, your hemoglobin A1C over a year was significantly improved compared to those who had no intervention. What's really interesting is that even if you have adequate or high health literacy, you also showed some benefit for having improved communication, or what I call more health literate care. So this is a great example of showing that these interventions based in health literacy can actually have effects that you can actually see, and you can clearly benefit not only low health literacy patients, but really all patients. So over the last several decades, this work has been done now, not only in diabetes, but in a lot of other situations with chronic diseases as an example. But what about surgery? You know, as surgeons, we sometimes are behind the 8 ball in many of these areas like health literacy. But in the last several years, within the last 5 years, more and more work has been done now as people realize that health literacy is very important in surgery too. This is a paper by Dr. Baker, Sam Baker, one of our residents, who showed that patients with limited health literacy are at higher odds of being readmitted to the hospital, looking at the VA population. Dr. Cameron Adries and Dr. Wright did a really fascinating study published in JAMA Surgery a few years ago that clearly showed that patients with limited health literacy had longer length of stays. Now, you might ask, okay, does this really matter? And I'm going to get into this because it really does. And it ties into length of stay, it ties into enhanced recovery, and length of stay, I think, really actually does matter. But this paper clearly showed another distinct association of health lit and one surgical metric. Dr. Tice, within our group, recently showed that low health literacy is also associated with major complications after colorectal surgery, specifically organ space infections. So in the red are patients with limited health literacy, and you can see they take up a huge proportion of those with post-op complications. And it's primarily these organ space infections, leaks. Those are sort of issues. And this may tie into bowel preps. And when we talk about medication adherence, it actually could tie into patients not understanding about bowel preparations and therefore having a higher risk of having infectious related complications. And this is also despite going enhanced recovery. So this slide just summarizes sort of the evidence that's out there, showing the association of health lit and surgical outcomes. But on the very last row there, this is a really fascinating paper that came from a group in China that associated health literacy with your adherence to specific enhanced recovery components. And this is sort of, I think, really a great paper that really, I think, captures all this stuff here, right? Because you may ask, okay, how does health lit then lead to a bad surgical outcome, right? And this is the mechanism. This is an idea of one of the potential mechanisms as to how this happens. You have limited health literacy, and you might not be adherent to some of those aspects of surgical recovery that enhanced recovery really defines. And because of that, that may lead downstream to these longer length of stays, more post-op complications, more readmissions. And so that's a really fascinating area that I think is directly applicable to all the folks here on this call who do enhanced recovery and are very familiar with this. Now, the current state of research in surgery, as you can see, is continuing to increase. And Dr. Chang did this really nice study showing that within the space of surgery, most of our work is done in certain specialties. So it's really wide open, right, for those on the call. I know we're colorectal heavy here, but you can see that actually not much is done even within colorectal. The other fascinating thing that's important to know is that within all the data that's out there on surgery and health literacy, we can at least easily say that at least a third of our surgical patients have at least low health literacy. And this is probably an underestimate. It's probably much more than this. But the idea is that every day you're going to see patients with limited health literacy. And hopefully I've shown some evidence that that is actually associated with risk for having poor surgical outcomes. And really where the space is now is focusing on understanding these mechanisms as to why that happens. And then ultimately, this is where our lab is most passionate about, is developing interventions to address this fundamental issue. So to try to bring it home and to make it as concrete as possible, I'd like to share some of our work in Alabama. So 2019 report on COVID for health rankings across the United States, you can see that several states like Hawaii, Vermont, Massachusetts rank very highly in health outcomes. And then at the other end of the spectrum here are those who rank the lowest. And you can see Alabama is down here with Oklahoma, Arkansas, Louisiana, Mississippi. And specifically, if you look at the actual outcomes, Alabama is particularly bad, okay, in terms of health outcomes, which might not be surprising to some. Just a few years ago, in 2018, the UN Special Rapporteur of Human Poverty came to Alabama, and just an hour south of where I am right now, went to Selma and just saw this is such an abject amount of poverty, and this is something that's real, that we have a lot throughout the United States, but particularly prevalent here in the Deep South. This is a disparity map. You can substitute any word here, and this is what it would look like for obesity, smoking, health literacy. And you can see, for those not familiar, where Alabama is right here, smack in the middle of all this red. So we kind of started looking at surgical disparities looking specifically at racial disparities between Black and white patients. And Dr. Gunnels, one of our colorectal surgeons here, did a really nice study early on looking at disparities in readmissions, specifically within patients with inflammatory bowel disease. And essentially showed that on adjusted comparison, Black patients who identify as Black with IBD are at particularly high risk of being readmitted. Dr. Malik and his team also looked at this and saw that there are many patients who were at risk for being readmitted to hospitals for Crohn's disease. And Dr. Gunnels looked at a follow-up study that patients who are Black are also at risk of not having stomas reversed. So the point is, there are many, many racial disparities within surgery. And the question is, why does it happen and what can we do about it? So around this time, just a few years ago, another study came out that looked at these disparities, specifically in length of stay. And what Dr. Tran and Ravi showed was that looking at ACS NSQIP data across the entire country, if you just looked at some major procedures, some of these are shown here, like colectomy, patients who are Black had much longer length of stay. So this touches that length of stay thing I was talking about earlier. And it's actually almost like at least a day longer in the hospital for patients who identify as Black. Now, does this really matter? It does, okay? Because I think the throughput through hospitals is exceedingly important. And even an incremental amount of length of stay that can be saved can have a much more amplified effect for your hospital system. Dr. Matt Gilia, a resident with us, now also colorectal surgeon, that did the follow-up study to this, saying, okay, well, that previous study, people had complications. So what if you take patients who have no complications, right, in ACS NSQIP? They should have a flawless recovery. Would there be differences in length of stay by race? And we would think, no, why would there be a difference? But there still was almost a half-day difference for patients who are Black compared to patients who are white. Despite having same operations, same pre-op demographics, still, there was a significant difference between the two groups. So this kind of got our lab thinking in terms of, okay, well, so if we know and see across the country, across our state, that patients who are Black have longer length of stays, what can we do about that? Well, coincidentally, we all know about enhanced recovery. Enhanced recovery, at the end game, it improves recovery, and because of that, you have reduced length of stay. So we asked the question, can enhanced recovery actually reduce then these racial disparities in length of stay? With the hypothesis that it would. So this is one of our very first grants that we got from the SSAT to look at this question. And so with Dr. Wall, one of our residents, looked at this, comparing pre-enhanced recovery to post-enhanced recovery patients in 14 and beyond 15, looking at length of stay. And so what you saw was that patients who are pre-enhanced recovery, if you use the ACS NSQIP calculator and put in patient information and say, okay, what's the expected length of stay? Not surprisingly, the ACS NSQIP calculator would say that the length of stay should be the same. Similarly, enhanced recovery patients should be about the same length of stays, right? So that's what we'd expect. But in reality, this reflects what we saw across the country. Patients who were Black had much longer length of stays than patients who were white. And both patients actually stayed at UAB in Alabama longer than the expected length of stay. So this is pre-enhanced recovery. But once you started doing enhanced recovery, what we saw is that both patients do better than expected. And this whole disparity in length of stay is essentially eliminated and sustained. So this is one of really a big key study that our lab has been able to demonstrate, suggesting that enhanced recovery, by standardizing care, you essentially ensure you deliver best evidence care to everybody, right? Regardless of who you are and what kind of a demographic or identity you have. If you do it over and over again consistently, you have great outcomes for everybody. And so that's a key principle, this idea of standardizing care, which is something that I think enhanced recovery does exceedingly well. But it also points to us that we weren't doing something before, right? Were we walking all patients at the same rate, right? Before we did enhanced recovery? Were we educating patients in the same way and making sure everyone understand? We probably weren't. But before we kind of gave high fives too, we actually wanted to dive a little deeper using qualitative studies into what is actually experienced by patients who go enhanced recovery. So great, length of stays are better. But what about all the other things that we care about in colorectal? And so we did some interviews, one of our first qualitative studies with Dr. DeSantis Marquez, one of our residents, who did a really great study interviewing all these patients about their experiences. And what's interesting is that what came out of this was this idea of the value of information, of accurate, trustworthy information. No matter who you were, everyone cared, number one, about this. With some still differences experienced by patients who are Black, as listed on those bullet points. But the point of this paper is that this paper really illuminated and showed us this idea of health literacy. Because to be honest, before this study, I personally knew very little about health literacy. This concept, even though it's been out there, really only came up because of this. So, let's see here. I'm sorry, I think my video froze. Okay, can you guys still hear me? I think something changed on my system here.
Yep, it's working.
Oh, okay, cool. Oops, sorry. Okay. So going back to this model of care that you see here. So how do we do this now? So how do we approach? So what we do is we focus on this model. On the front end, we identify health literacy, and on the back end, we focus on understanding and addressing it. So some of the work that we've done on the front end in our group is measuring health literacy within surgical populations. And so what we've shown here is that, as you can expect, you can measure health literacy, number one, in the surgery clinics. And there actually are different graphics. Patients who are Black, older, and male actually were at the highest risk of having low health literacy. And so even in your clinics, right, there are certain populations that are at risk that perhaps you can deploy more resources and focus more on helping patients understand things. Now, the other issue is this idea of low health literacy patients, right? The red flags. And I think there are many, many metrics where you can focus on identifying patients with limited health literacy, but there's also things that you can see in clinic. And can you still see me, guys? Just trying to make sure.
Yep, we can see you.
Okay, perfect. Sorry, everything's like frozen on my screen right now, so I just want to make sure. So these are sort of the metrics that you can look at, okay, for not metrics, but really some characteristics for limited health literacy. The patient who has the vacant look, the patient who's in your clinic, who doesn't ask any questions. And this is classic. And I think everyone on this call can sort of sense this when you leave a room and you're saying, wait a second, like that patient and their family had no idea what I just said, right? So, but these are some of the other kind of red flags, as we call it. And the point of this is that no one wants to act dumb. So everyone's, is like that feeling, no one wants that feeling, right? And so patients are trying to get out of that room as soon as they can. But what you have to do as a provider is that you need to recognize this and actually do things about this, meaning you can provide the actual time for questions. You can follow up and ask for teach back and say, can you explain this back to me? So that's the identifying piece. And like most research now, the more kind of, I think, value and interesting things is this understanding and addressing it. So what have we done about this? Well, the first thing is education and readability. So one of our team of med students went around our institution, all the specialties, and looked at all the written education material that was out there and rated them using the Flesch-Kincaid scale. CDC recommends reading levels to be 8th grade or below. NIH, AMA recommends 6th grade or below. And what this shows here is an average of all the readability scores for these specialties in terms of the material that's given to patients pre-op. And you can see that actually there's nothing that's actually below the 6th grade reading level. Oh, I'm sorry. So just going back to readability of this information, the readability essentially was not scored well. And there are specialties as shown here where there was actually nothing written at the recommended reading level, including our own colorectal.
Dr. Chu, we don't have your
is a really
slides
interesting
yet.
tool that you can use to measure it. Oh, okay.
You might need to reshare screen on the bottom in the middle with the green button.
Okay, is that better? Okay, great.
The slides have, yep, we got them.
Okay, sorry guys. I think my computer is like literally dying in front of me right now. Interesting. Okay, so material, including colorectal, nothing written at the reading level. PMAT, another way to assess education material, also shows that there's huge variability in information across what we use in the clinics. This is meant to show that on the far right, that internationally, much of the education material is really good. But on the left in the green is material at my institute at UAB, which was not good. So what can you do about this? So there are many things that you can do that take principles from graphic design and information design. The CARP is a technique where you work and make material better to be more understandable and more actionable. One is C, contrast, as you show here. The one on the right is far better than the bad that's written in blue. Alignment, keeping things organized, really is much easier on the eye to see things and to understand things quickly. Repetition and symmetry is important to make material better, and so is proximity. So these are all things that we all sort of intuitively know, but there actually is sort of a science behind this. So as an example, my daughter is very snarky, and she tends to write these things about me. But I love to critique them and tell her that there are many things that she could do that's better to make it more understandable and easier to read. So she's evolved in making things better, taking these principles of making contrast, alignment, repetition, you name it. So it becomes more understandable for anyone to read, including her own brother. But you can take this at another level and take material that you have in your clinic and bring it from what I call version 1s to versions 2 and 3 and 4. And this is something that we use within our enhanced recovery program to turn things that was initially all text-based as version 1 into something that's far more graphical, cartoon-like, because everyone understands cartoons, and to make it as simple and easy as possible for patients to follow and be engaging. And you can improve these readability skills from things that were very high to things that are actually closer to what where we should be. And the point is that you can make this material more understandable. And this really touches upon an area that I think you may see some things like ChatGPT being used to improve the readability of information. This is just a blow up of some of those graphics, and you can see that we make things shorter in terms of sentence structures. We add visual aids, white space. These are all things that can be done to give you more points and make things essentially more readable and understandable. And we do qualitative work with this and follow up, as you should with anything that you do with patients, to say, did this really, really help? This is just some data that shows that patients with limited health literacy do find material like this more understandable and prefer the newer version. And this is something that you can study, and we were able to publish on this one. We also took some other sides of the story too. I think everyone on this call in colorectal can use pictures. We tend to draw colons and show the anastomoses and the different reconfigurations that we use. And this slide is meant to show that you can take sort of these scribbles, work with collaborators, and formalize it into visual diagrams that are easy to understand and that can explain the different types of anatomy that we do for patients with reconstructions. And patients appreciate these drawings and can understand it much better than other drawings. And so part of our lab's plan is to really build this repository of pictures like this so that anyone can draw it and can use it off a website within their own clinics. So that's just a touching upon the education readability. What about support technologies? So technologies are out there. I think some of us are maybe familiar with patient engagement technologies. This is Seamless, one example of these technologies. It's one of those technologies that follows the patient throughout their entire surgical journey from the very beginning to the very end. It installs on your phone, and it's customized to your enhanced recovery program, and essentially is easy to access. It's engaging. You can do things back and forth with patients, and it really is another safety net, as I call it, for patients. But what's beautiful about these technologies is that you can actually very much synergize them with best practices in health literacy. So I talked about bowel preps. So rather than giving someone a page with strictly text written in paragraphs, you can actually now work on giving that education material in a more health literate way with cartoons, essentially. Similarly, this picture shows emptying your pouch. These are much more understandable than pure text. There's no question. And so you can deliver it now through these technologies and push it back and forth for patients to engage with and to hopefully adhere closer to what you need them to do. But there's a catch to all this. All of these technologies are great and they work for many patients, but we have to be careful that we don't actually leave people behind because not all use is equal. This is a paper by Dr. Tice and Dr. Xiao that looked at sort of the engagement with these technologies. And on the left, you see patients stratified by health engaged similarly. So patients with limited health literacy can engage with these technologies. But on the right, we stratify by race. And we can see that there are still differences by racial identity and engagement with these technologies. So there are other factors at play, is what this slide is trying to show beyond just health literacy. But technologies are going to stay. Telehealth is here to stay. So we have to be cognizant of making sure that we deploy these technologies in an equitable way. So what about provider level information and what can we do here? So you can study this too.
Sometimes doctors make mistakes. Anna, this is hard to fix. Using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
So that's a perfect example of the teach back method, where patients will say they understand everything, but you really have to ask, hey, if you were to explain it back to me, what would you say? How would you explain it to one of your own family members? And this sort of interaction in the clinic is, I think, super important. Written material, that's one thing, but your verbal communication and ability to make sure patients can understand what you're saying is super critical. In fact, maybe the most important piece of any encounter that you have with patients. These are just some quotes from patients who came through our clinics that talk about how really as a surgeon, like you really make the difference in terms of helping patients trust and understand what's about to happen. And so it cannot be overstated how important you are to this piece. So interesting enough, if you were to sit in a room and say, okay, do all surgeons communicate in the same way? And the answer is no. This is a study where we looked at 4 surgeons at UAB and essentially carried the conversations that were going on. This is just showing speech rate as one example. And what you can see is that there's actually a lot of variations in the rate of speech or words per minute. On the right are some examples of normal conversation, radio show hosts, auctioneers. I personally speak very quickly. I have to consciously slow down. This study, I think, illuminated some of my speed of when I talk. And it matters because the faster you speak, the less understandable words are. And patients on the other end actually can't really make sense of what you're saying. When you look at the words that are being used by surgeons, this is the Flesch-Kincaid scale. This is the SMOG. These are just ways to measure the understandability of the words. There's also huge variations as shown here between surgeons. Put it all together, the faster you speak, the less understandable you are to patients, by both of these scales. And so this is one thing that you can take away from this talk is ask yourself, when I speak to patients, how fast am I speaking? And can I consciously slow down? And I think as surgeons, I think we do tend to speak quickly and we use big words. And so this is an opportunity where you can actually really make a change. Now, on top of all this, patients with limited health literacy also have the shortest clinic visits. And so this is sort of keeps compounding on itself. Patients with limited health literacy have the shortest clinic visits. They have surgeons who speak the fastest to them and use the biggest words, right? So it's no wonder that patients with limited health literacy have challenges understanding that clinic encounter and what needs to be done afterwards. And the understanding is lower for patients with limited health literacy. So you can see this all comes together and keeps adding onto itself. So until you, I think, recognize this issue, that's the first step to really breaking this cycle of health literacy and the challenges that come with it. And what are the interventions? They're not fancy. They're not expensive. These are things that really at the individual level you can do as a provider. With the biggest things, I think, being things like teach back, right? Making a patient tell you how would you explain this? To slowing down, to using plain language, visual tools, pictures. We're surgeons. We, I think, learn a lot ourselves through pictures. So why not do the same for our patients? So together, these are all the things that I think we can do. In our research in our lab, really focused on this using technologies and using different ways to more align with all the levels of health literacy that a patient can come at you with, to hopefully modify things to achieve, again, the best outcome for patients. Now, the last thing here is just another slide to show you that this really can make a difference. This was published in Lancet and is a randomized trial where essentially they're dealing with atherosclerotic disease of the neck. And the intervention is actually on the left. What they did is they took patients and either explained patients their disease based on ultrasound, verbally in whatever traditional way they normally do it, to actually giving patients a sheet of paper with this exact kind of page on that left there, showing the amount of plaque within their carotid on ultrasound. And this kind of one intervention, this visual display of information to help patients understand their burden of disease, completely changed patients' behavior for a year. So that years they had better scores for their kind of cardiac risk factors. So this just tells you again that health literate based interventions can make a difference and change things down the road. Our group is very interested in enhanced recovery and how can you improve the adherence to all of those components of enhanced recovery through health literate ways, because we've shown, and the group and from China, that patients with limited health literacy do have lower adherence rates to components such as ambulation after surgery, or early diet after surgery, or pre-op blocks that are received before a surgery. So those, I think, are things that we can do if we can better match patients at their literacy level. So I think the future of what we kind of hope to do and to work with our partners and people on this call is that surgical care is complex, but we can do different things at each point of contact to improve and deliver best practices in health literacy, which are shown on this slide. And just to provide even bigger context of health literate care really falls within, I think, a greater space of health disparities. And that to address these maps of health disparities, we have to do all of these different things to really hopefully change the needle and make maps of health disparities look more like this. So in summary, health literacy is very common. I hope to have shown you that it is absolutely related and is a key determinant of outcomes. And very practical things to take away is these three kind of buckets here, keeping things simple, both in your written and verbal interactions, using the teach back method, and really, really focusing on visual aids, right? Drawing pictures for patients in your clinic, in the hospital, when you're grounding on by the bedside, right? Using those boards on the wall, they really, truly make a difference for patients because health literacy absolutely matters. So with that, this is my email. Happy to take questions from the group here. Apologies for that technical snafu. We've all been through this, and I can't believe it happened today. But thank you all for your time.
Thank you very much. That was a fantastic talk, and I can't wait to get the video edited all down so we can snip out that middle part. But there are so many things that you guys have done that I think can be kind of expanded to practices around the country. We have one comment or a question from Dr. Wright from Surgeon. He says, how is your institution logistically measuring and collecting health literacy? Is this something that exists within most available EMR? And if not, what's the barrier for it to be included within the EMR?
Yeah, I'm sorry. You broke up just a little bit on me there. I'm not sure if you could repeat that or, oh, here it is. Okay, perfect. I see the chat box. Okay. Okay, yes. So we're using the Brief, which is a 4-item health literacy screening tool, very easy to administer by our triage nurses in clinic. So when patients come in and get their normal sort of routine questions, this is included as sort of a module. It takes about 30 seconds to administer. So it's not as onerous and it's easy to incorporate. So that's within, we use Cerner. So that's just built within Cerner. And then that gets inputted into the system there, which is where we get all this data. Is this something that exists within most? Yes. So I think a lot of the EMRs do have, and if not, this is something that can be incorporated. We actually work in rural hospitals in Alabama too that don't have Cerner, or Epic, and have very more simplistic sort of EMRs. And in those situations, that's more a kind of old school manual that you just basically incorporate into the workflow for your clinics. The flip side is you have to, the flip side of all this is that you have to, do something with the data, right? If you're going to measure something, the intent is that you're going to do something about it. And we use it to basically for our research and to really kind of target areas where when we develop an intervention, we can focus on this particular population. So I hope that answers your question. And the barriers, just going back to the barriers I think is the workflow, right? It's easy enough to say, okay, do this survey, do all these surveys. But I think being intentional about it and having the long play of what you're going to do with the data helps people like your nurses see why it's important and why they should be doing that. I see the next question is, how did you get into health literacy research? Yeah, so this was not planned. My interest has always been health disparities, and it was only through sort of the work in that space where we're trying to understand why disparities happen through our interviews and qualitative research. This theme of information being so critical to patient understanding kept coming up over and over again. And so that's what got us into health literacy. And then from that space, we realized there's this whole world of health literacy that's been done, as you saw the research, like since the 1980s, that have all been done in all these other specialties. And so this became an area where we asked, why can't we apply a lot of these learned lessons, but to our surgery world, which is very unique. Surgery compared to some of these other things like diabetes, it's very different. And that's where sort of the innovation is applying these principles to another space, another environment. And this has just continued to grow within our lab. And as you see, we've been very fortunate to receive funding from NIH and many societies for this type of research. So I do hope that comes across too, to say that you can very much build a career within this area. It doesn't have to be, a clinical space. These principles of health literacy, in many ways, are even more generalizable, which is something that the NIH really is trying to emphasize. So what is the one intervention you've implemented that has made the biggest difference? Yeah, so one of the things that we've done is the education. So, and this is under the guise of enhanced recovery. So, enhanced recovery, right? Great stuff here. But enhanced recovery, as you know, one of the main components is pre-op education. And so what we found is that the education that is given, as one might expect, can also vary significantly depending on, right, who's giving it. As you saw through the verbal characterizations we did of conversations to the written material. So standardizing that education has been a big priority for us, for our institution that we've worked on. We haven't quite measured the effect downstream yet, but we think by focusing on standardizing that process, we will be seeing it down the road. And that's part of a big R01 that we've put together that hopefully we'll get funded on this year, that is focused on sort of standardizing sort of those components of enhanced recovery, and then show that patients with limited health literacy, right, even though they're at risk of having more complications, if we do this kind of thing, then down the road, maybe we can eliminate those differences and complications. I see another question here by Dr. Batra. Big challenge, of course, is limited time. How long are your new patient averages on visit? Do you have AP include added education? Thanks so much. Great. Yeah, so great question. Okay. So yes, the bottom line is I can do all this talk about all the great things that we need to do, right? That we all know we need to do, but in reality, we're pressed with time. So our clinic visits, our EMR is slotted 15 minutes for our return visits, 30 minutes for new patients. But in reality, I think we all double booked, we all triple booked. And so you really are spending maybe 10 to 15 minutes of time with patients. And this is a real problem. And you're not going to be spending an hour with the patient, even though that might be great. So we call this a sandwich approach, meaning the key is to provide, it's not just you providing the education, it's other people. So this question alludes to APPs. So if you have APPs in your clinic, fantastic, right? But the key is like a sandwich, you have to be consistent, and everything sort of has to be on the same page. So in your surgery clinic, if you're giving some education material on enhanced recovery, and you need to do this before surgery, you can expect these things after surgery, like we want you to walk the night of surgery, we want you to have some diet the night of surgery, right? That information also needs to be given in your anesthesia clinic. So if your anesthesia folks are seeing them before surgery too, that information also needs to be consistent. And so you sort of start adding all these layers, right, together, so that at the end you have this package of education that's been delivered over the entire sort of a much longer time period that is consistent and accurate. And I think that's the key to providing health literate sort of education to patients while accommodating for, yes, the limited time that we all have in clinic. The technology piece, that's another great thing too, right? That's another way to provide another level of education that really, in a sense, is sort of done at the time, on the patient's time, but it can also reinforce things over and over again. So that's kind of I think our strategy for this. And realize that our education material was not consistent. So our anesthesia providers, for example, were saying things differently than what we were saying. And so I think identifying those variations is also critical to this. So another question about the graphic builder with the ANNALS. Yes. So this is interesting, and this is resource intensive. There's no question about it. So one of our lab's goals or dreams is to sort of build a repository, free, basically open source or whatever you want to call it, of sort of these imaging, so that it can be just go to a website and you just download a PDF and print it out in your clinic, right? How easy would that be to show the different configurations of reconstruction? So we work, it's ironic enough, graphic designers, they're everywhere. We happen to have, I happen to have my sister-in-law who works for Nickelodeon and for Marvel Comics and draws comics, help me with those pictures. So And we did as part of a research project just to demonstrate proof of principle that you can do that and that patients actually will rate those pictures like as highly understandable and easy to read. So those pictures are actually online right now within our lab. Resource intensive, right? So to cash now is the question, can we leverage now some of these other technologies that are out there, right? So ChatGPT is text-based. We have actually other equivalent graphical programs out there to draw these things, right? And so, yes, so the idea is that, and this is where the research is open right now, right? So, okay, fine, we have resources like people doing this, but now can we have machine learning and these technologies help us now? So that under-resourced hospitals, for example, they don't have education departments who standardize information, and then they use these technologies to standardize education. So that's a big research area that we're actually moving into very recently with all the hubbub about ChatGPT that you're hearing about. Yeah, so these are great questions. So I think, if I can just, say that this space is wide open, it's exciting. There's lots of really in these areas of research that makes you think a little bit outside the box, which is, I think, great. And I think it's one of those themes that comes up every day in your clinic. So you can take it back to your clinical practice.
Thank you so much. Yes, I totally agree. That's kind of why I was hoping to have you talk with us, because I think it is not only a super interesting research area, but also super applicable to our day-to-day clinical practice. Thank you everyone for joining us tonight. If you have any last questions, feel free to put them in the chat. We can get them to Dr. Chu, and otherwise have a good rest of your Sunday.
Great, thank you everyone.